Yeah, we should be starting in a minute now. It's now about 4 minutes past the hour. My name is John Black Kauche. I work at the Uganda Cancer Institute in Kampala. I am a medical doctor. I am also a digital health researcher. And today we have very interesting speakers whom I'm going to introduce briefly. But to give you a bit of housekeeping, please mute your microphone if you're not speaking, so that we don't get a lot of distractions. But if your bandwidth allows, keep your videos on. You can do a bit of interaction with that. You can give a thumbs up, you can clap, raise your hand. So it helps to be a bit more interactive when you have the video on. Use the chat at any point during the presentation to ask questions, to make comments, and if you need, you can enable subtitles on your screen to get text. And again, sessions are recorded, so the recordings will be shared. Now, the topic for today is navigating public-private partnerships to leverage opportunities while promoting equity and sustainability. Again, navigating public-private partnerships to leverage opportunities while promoting equity and sustainability. I'll be sharing the session. I hope someone else can join to co-moderate. But we'll have a 15 minutes didactic presentation by Dr. Oyebanji Filani, who is the Honorable Commissioner of Health and Human Services in Ekiti State in Nigeria. And then we'll have a case presentation by Dr. Francois Ukindi, who is a Division Manager of Non-Communicable Diseases at the Rwanda Biomedical Center, the Ministry of Health in Kigali. And then we'll have some discussions after that. So I hope everyone is ready. The speakers at least are. Mishka, maybe you can advance the slides for the presenters. I'm gonna switch over to mobile because I have to pick children from school, but I'll be doing that while moderating. I've done this before, so it should be all right.
Multitasking, quite like cancer control. There you go.
Yeah. So to begin with the didactic presentation, Dr. Oyebanji Filani, who is a public health economist with over 17 years of experience in health financing, health systems reforms, will be presenting. He currently serves as the Honorable Commissioner for Health and Human Services in Ekiti State, Nigeria, where he's responsible for development of policies, providing oversight in the implementation of innovative and sustainable programs towards fulfilling the state's universal health coverage. He has worked previously in Ministry of Health, and he has also worked with the Minister of Health in Nigeria. I'm giving a brief sort of summary of his very impressive CV, but it is attached in the invite, so you can go through that. I want us to start, and then I'll introduce Dr. Francois when his time comes. But I want to allow him Dr. Filani to start the presentation. Are you ready, Dr. Filani?
Yes, I believe I am. Thanks a lot, John Black, and thanks again to everyone who is on the call. I do hope that you can see my screen. I want to see my screen just to be sure.
Yes, screen is coming through.
Okay, just give me a moment. Awesome. All right. So first and foremost, I think again, thanks to Dyer, Dr. Joseph, who asked that I participate in this. I think for me, primarily one of the reasons why this is of interest is haven't done some work at the federal level with respect from a policy perspective to ensure that we can expand access to non-communicable diseases, in this instance, cancer, diabetes, hypertension, in terms of new treatments, but just making sure that more people who need care are able to get it. And now working in the state and doing something similar, it was also important for me to hear from those who are on the field, who see the patients a bit more regularly, who know where the shoe pinches from their perspective. And so when I saw the topic, I thought it was important because, yes, there's a public-private partnership angle, but there's also how do you promote equity and sustainability of whatever we do. So what my presentation will try to show is what, we have done in Nigeria, and to a smaller extent, what we've done in Ekiti State, where I see potential opportunities for partnership with the private sector, and what I consider some of the things that I consider that is outstanding that needs to help ensure that we can better improve that partnership and leverage on potential opportunities. So one thing that is clear, and this is not just either for Nigeria or for Sub-Saharan Africa, but across the globe, is that health is a fundamental human right. And governments, have to play a role in ensuring that we're able to provide, adequate care that is of good quality and that meets the needs of the teeming population. But the reality that we face today is far different from what we faced in the 60s or in the 70s, where a number of countries try to push towards that, particularly with governments taking a significant role in service delivery or in funding for care. And some of these realities include the increasing life expectancy, that we're seeing, and of course the attendant comorbidities that come with that. The challenges we have with emerging public health issues. We've seen Corona in the last 2-3 years, but also across Africa, Ebola, monkeypox in some countries, and a few others, right? Then we have the non-communicable disease, the twin burden of non-communicable and communicable diseases in Africa, and the implications of that on costs, right? And of course, the demand for newer technologies. In the instance of cancer, we're moving into hormonal treatments, we're moving into immunology. So there's a whole lot that means that government may not necessarily have all that it takes financially, or even in terms of service ability to deliver the service to provide care for the teeming population. And so it becomes imperative that we begin to rethink how we engage and how we can leverage on private sector capacities and capabilities to be able to drive access, equitable access, and in a sustainable manner. My next slide then speaks to what I consider what the health system ideally should look like, and how it ideally would function if you want to achieve your goals of better health, reducing financial burden on people, and ensuring that the system is responsive to the needs of everyone. And I've highlighted 4 primary areas that I think that the private sector can play a role. One is around financing, around investment in human and fiscal resources. The third is around service delivery, and those highlighted are the ones I've put in the dark calculated boxes. And of course, around the data systems, monitoring and evaluation, and accountability framework. So those are areas that private sector certainly can come into play and play a role. But government, in its role as in playing in governance and the stewardship, must also provide that enabling environment for all of these other things to thrive. And that brings me to, in Nigeria, some of the things that we've tried to do with respect to the policies. While I was in the ministry at the time, at the federal ministry, and I believe that some of these policies have now been updated because typically they are 5-year policies, 2017 to say maybe 2022. So I believe that the 2023 to 28 will probably be maybe just about to be released. Is that within the country, there are specific guidelines, right, for public-private partnerships in the health sector. And there are even policies beyond that, there are policies for incentivizing investments in the health sector. And so there is a first layer of commitment from government by putting this enabling environment down, but also ensuring that the policies are in place for us to be able to leverage private sector capacity, whether through funding or through or technical expertise. And we've done this in a number of ways beyond the policies. I give example to start with the financing. The Nigerian Sovereign Investment Authority, which is a quasi-government organization, put together its own internal resources, but was also able to raise debt through private capital to operate a set of centers within existing institutions. So one of them was in which Dr. Joseph currently does some work as the Nigerian Lutz Center, the Cancer Center. They've done something as well in Aminu Kano, one of the states in the north, and another state in the southeastern Nigeria. So they mobilized their own resources, but we're also able to mobilize additional capital to be able to build these facilities. And what this has done, and I'll tell this story. As of 2016, we did not have in country any, for a consistent period. So you could have, say, 2 months, or you could have 3 months, but most of these machines were constantly breaking down because they were either old or we just could not service them as at the right time. So treatment of cancer in Nigeria, a number of people had to travel out. Either you go to India, sometimes even to Ghana, just across an hour away from Nigeria. But over the last 3-4 years, off the back of the policies that have been in place and additional investments that are coming into the system, we're seeing a whole lot more cancer centers, as an example, that are coming into stream with provisions for people to be able to provide, to be able to access good quality care. So that's around financing. There's also around service provision. A number of private sector players within the space, either in the diagnostic space or in the radiology space, for instance, are able to put their resources in place, but not just in fact from a resource perspective, is to say, look, we're able to deliver these services. And in certain instances, they put them within teaching hospitals or within government-owned hospitals to be able to render this care to at a slightly lower price than they would otherwise have charged if it was outside of government building. And that provides a pathway to a more equitable access to care. In some instances, and I know in certain states, cases like, say, transplants that need to be done, or specific care that needs to be taken, maybe surgeries that cannot be done within the hospitals, are contracted to private sector players who are able to provide this within their own hospitals at a negotiated rate. And finally is, of course, the engagement with pharmaceuticals. And this cuts across all sorts of commodities, whether what they call the orphan drugs or the OTCs, where government is engaging directly with the manufacturers to be able to get high quality drugs at a far cheaper rate, because you've done your quantification and forecasting, and so you can procure either in bulk or pay on a staggered basis. In Ekiti, where I currently serve as the Commissioner for Health, I'm giving 2 specific examples, but I'll focus, because of time, on the one that has to do with the topic that we're speaking to today, which is cancer. And this is in late 2021, alongside some of our partners, WHO, I think the Clinton Health Access Initiative, and Roche and J&J, we came up with a tripartite engagement to begin to rethink, how we can expand access to cancer-related services in the States. So now we have a cancer policy, which is great, but beyond that cancer policy is that we've been able to attract some of the equipment that are required to provide the services. And these equipment have been put in our government hospitals across the entire state, again, speaking towards, the equitability around making sure we expand access. Beyond that is the ongoing negotiations that are planned to have with some of our manufacturers to ensure that we can get this, some of the necessary commodities for treatment of cancer, for chemotherapy, at a far cheaper rate than would otherwise have been accessed in the open market. But I think that, I've tried to speak to some of what is good that we have seen, and where government is recognizing the need to attract private sector, recognizing the need to engage, and I've shown over the last 2 or 3 slides how well we've done that either at the national level, or the extent to which we've done that either at the national level, but also at the state level. But I think a lot more needs to be done. And part of what needs to be done, I've highlighted some of them, is very, very clear regulations around clinical trials. Particularly, I give examples in Nigeria. I know Ghana has done a bit more. A few other states are also, countries rather, are also doing better in this regard. But this is one area where we can, as sub-Saharan Africa, we can be more. We can show a bit more commitment to the newer technology newer devices, newer medicines require that, you have a significant number of people of varying race, included in the trials from day one. And that's when the technologies or even the devices or the commodities can then be said to be that where we can measure the efficacy of such commodities, in the different races. The second around this, and so government has a role to play, in making sure that these clinical trials are properly done and that we have the capacity to be able to do it at large scale. The second, of course, is around human resources for health. And I think this is critical and important because as we begin to think about, even the more specialized cancer cases, pediatric radiation as an example, or any of the other areas, is to ensure that we begin to invest adequately in our human resources, recruitment, upskilling, right, and then also motivation so that they are retained to be able to provide this. There's a conversation around better review of the tax structures and rates in country. And of course, research is important. I always give this example of COVID, where there was concern more broadly within sub-Saharan Africa as to the inequitable distribution of vaccines, COVID vaccines, at the outset. And my point to a number of my colleagues has been, okay, well, maybe that was a problem, but we have a responsibility as sub-Saharan Africa to be able to then say, okay, what is our contribution to the world around COVID? And that contribution has to be around research. Research because unlike other clients, we did not necessarily have as many people, at least based on the data that is available, right, who were, in terms of the mortality rates in Africa, was not as bad as predicted. And so it was important that, beyond the anecdotal evidence that we have, thinking maybe it was X or Y, that proper research is coordinated around this, that gives, that contributes to the body of evidence globally. And I think that's something that we should take into consideration, and government certainly has a role in it. So these are some of the areas that I think we can certainly do more. It's by no means exhaustive. And of course, as a policymaker in my space, I think, just listening to the team as well and hearing from you all who are on the field would give us a bit more insight as to where and how we can work together going forward. So thank you once again for the opportunity to present, and I'll be happy to take any questions or just listen in till I have to leave. Thank you.
Thank you so much, Dr. Filani. I see a lot of similarities with Uganda and I think many other countries, but I also see some differences. I like that there's already a policy to guide public partnerships in Nigeria. I think many places don't have this already set. But I think there will be several questions coming to you. Issues around, for example, in Uganda, the fact that cancer care is quite expensive, and so private, like hospitals don't want to venture into that. I hope you stay on the call and take some of these questions. I encourage the participants to put them down. Maybe Dr. Filani can write responses to them in the chat. But I want now to hand over to Dr. Francois, who is from the Rwanda Biomedical Center, where he is the head of the division that is responsible for non-communicable diseases. So I guess that goes beyond cancer, but other, diabetes, hypertension, and all these other conditions. So he will give us more of like an experience with a private company or a foundation, Electa Foundation, which they've been collaborating with recently to screen cervical cancer, which is an important public health issue that we are trying to eliminate in our lifetime, according to the WHO call. Of course, Dr. Francois, you can also share other examples beyond Electa Foundation, but the floor is yours now.
Yeah, thank you so much, John. And it's really a pleasure to be here today and sharing our experience working with, of course, it's one of the examples, working with Electa Foundation to scale up or to scale up the cervical cancer screening services in our country. And as Dr. John Brack said, I'm Dr. Francois Winkindi. I work for Rwanda Biomedical Center, which is the implementing entity of Rwanda Ministry of Health, where I'm in charge of coordinating the prevention and control interventions related to non-communicable diseases that, of course, including cardiovascular diseases, diabetes, chronic respiratory diseases, cancer diseases, but also injuries and disabilities. So briefly, just maybe I put together a few slides. Just maybe I will start by just giving you a quick overview on how on the cervical cancer burden in the country, but also cancer in general, and also explain more on how we are working with Erecta Foundation to fast track or to speed up the cervical cancer elimination agenda in our country. So briefly, and I think some of you might not have enough information on Rwanda. So it's we are located in East Africa. So it's a small country with a population of around, now we are counting 13 million people. So the cancer incidence is estimated, this is by the WHO, at around 9,000 new cancer cases, but also the mortality is high as it is in other, low and middle income countries. We are every year registering 6,000 deaths. So if you look at the top 5 cancers in both sexes, so we have breast cancer, we have second, we have cervical cancer that I will be focusing on, and then prostate cancer, stomach, and also liver cancer. So again, this to show, this figure is also showing, the estimated incidence of cancers in Rwanda, but of course we are using those estimates from the GlobalCan. So where we have now cervical cancer as the second most incident cancer, but based on the data we have in our cancer registry, we are diagnosing around 50% of expected cancers in the country, because now if you look at the new cancer cases cervical cancer cases that we had in 2020, we had around 617 new cancer cases, and yet the WHO are estimating like around 1,200 new cancer cases in the country, meaning that there's still a lot of work to do to be able to really have to detect and also to bring those other cases that are still in the community into care. So again, this is the data from our cancer registry. Again, this is to show how really the incidence, if I can say, of cancer cases has been changing in the country. So since 2007 up to 2020, these are the validated data you have in our cancer registry. You can see that really numbers are increasing, but mainly because we have improved the diagnostic capacity, but also the of our people, related to cancer has also improved. But of course, with all of these initiatives of cancer registration and also awareness of healthcare providers has contributed to this increase of cases. Again, these are the data from our cancer registry. You can see that top 10 cancers, even if of course in terms of quantity, we are at let's say 50% of the estimated incidence. But if you look at if I can call it type of cancers, it's really almost the same as what we are having from GlobalCan, because now our cancer registry is reporting to the GlobalCan. So again, breast cancer comes first, and the second most frequent cancer is cervix, prostate, and then stomach and liver. But again, we are aware that really what we are seeing is really much rather than what really we should be doing. Seeing. That's why much efforts are being put on on awareness, but also screening services, focusing mainly on these two cancers, breast and the cervical cancer. So, because these are the cancers, as you know, we can detect early and also be able to treat successfully once patients have been identified at early stage. So my next slide now will be mainly focusing on how we started the collaboration with Erecta Foundation, and also briefly what we have been able to achieve over the last maybe 5 months. So because this collaboration is very, very new, because also this foundation is also new. And I think, some of you don't know Erecta Foundation. I think it's a Swedish organization and was, I think, recently created. You see, it's in January 2022. So they have a mission to improve cancer care access in the income countries. So I guess so. Maybe many of you are familiar with Erecta as a company, and this is regarded as their corporate and social responsibility arm, trying also to support different countries to improve cancer access to cancer services in our countries with limited resources. So after its creation, I think it's like 6 months later, we signed an MOU, a 5-year MOU with the Ministry of Health, with the goal to strengthen cancer prevention and control in our country. And then we said that, okay, let's start Moya, and we started on a cervical cancer screening project in one of our districts called Gichumbi. And to pilot a new screening model that would help really to go faster in our cervical cancer elimination strategy plan, but also inform how we can really scale up services in other districts. So again, I think most of you are familiar with these 90, 70, 90 targets. So I put it here just to remind us briefly. Our collaboration with Erecta Foundation is focusing on the second and the third pillar, mainly secondary prevention, but also treatment. But we can also call it tertiary prevention. So but of course we are also working on the first one, but mainly on awareness, but of course related to trying to bring people to their facilities for screening, because this first one is not the vaccination one is not included in our collaboration, because here the country has done a great job, because now our vaccination program is really, the coverage, the vaccination coverage is high, so above 90. So that's why we're focusing on these 2 other pillars where we still have a lot to do. Just again, this is the overview of the project was really to bring cervical cancer screening services in one of our districts, which is called Gichumbi. And the goal was to screen in the first phase to screen 20,000 women, equals to 37% of eligible women and we gave us really a shorter period, 4 months. So you can see that in this district we have 54,000 eligible women, and when you say eligible women, we are talking about women living with HIV between 25 and 49, and also if you go in the general population, we are using this range of 30 to 49 years old women. So these are the main interventions that we have in our project. Of course, first we have HPV testing, and then for cervical cancer screening, and those women with precancerous lesions, we treat them with a thermal ablation. For those with extended lesions, we go for RIP, and then we make follow-up, but also be able to do the diagnosis and also the treatment of advanced or invasive cervical cancer cases, but also support those ones with advanced disease to access palliative care services. But again, in all of this, make sure that really we are also doing awareness campaigns, but also public education. These were the main interventions actually. So it was like end-to-end program, just from screening up to, palliative care. In that district, nurses or midwife, therapeutic in the community. To screen to pay only. To screen it, so cancerous lesions. During this at our cancer center. For the transport patients have to pay 10% as a co-payment. So for those poor people, cancer management is expensive. The project also managed to pay for this 10% for them. So these are some of the little pictures showing how, to also, the first one, you can see that, we were with our former Minister of Health launching the program, but also with these other partners that we were working with. So, these are, where you can see that women are coming to the facility to seek for services. But also something that I can say here is that during the cervical cancer screening, we are also combining it with breast cancer early detection, especially clinical breast exam for those asymptomatic women. So to be able to provide women-centered services, not only focusing on cervical, and tomorrow the woman comes back with, breast cancer stage 4, and yet, she was seen at the facility. So then you can see that in one of these pictures that, a nurse was doing a clinical breast exam to one of the women that presented to the facility. So again, this is also to highlight that community health workers were very key in our program. So especially educating the community. So as I'm finishing, so some of the lessons that we've learned is that in order to be able really to have these meaningful partnerships, to make sure that you are not being driven by the partners or the partners' interests or agenda. So you should have clear national cancer control plans, that have that are guiding the partnership, but also make sure that really the partnership should be responding to the national needs, not really coming, having those partners with their own agenda and they come ask you to modify your own agenda. And of course, you should really have your clear needs and asks, but also you should have the government or the Ministry of Health having the oversight on what's going on. Make sure that you are owning each and every step of the project. You should have also an organized health system to be able to accommodate those new interventions. A joint monitoring of the implementation of the project is very key. Ownership of the facilities, because the project is here today, but should really continue, and also have that active involvement of local partners, but also other stakeholders. So we also managed to technologies, like we didn't have a machine in our systems, but we have seen that it's really working well, but also be able to document the learnings and also to be able to inform the So briefly, thank you so much. This is what I prepared just for you. Maybe more information will be provided during the Q&A session. Thank you.
Well, thank you so much, Francois, for sharing what you've achieved with the Lecter Foundation. I see that Dr. Filani is going to be boarding, I guess. Thank you so much, Dr. Filani, for your presentation. I didn't see any questions.
Thank you, John Black, for having me, and everyone. Yeah.
Yeah.
Thank you.
But I think we have you on email. We can ask you some. If people want to follow up with you, can do that. But
absolutely, that would be fine.
Yes, and nice flight. So I think now we can have with Francois, but also others in the group who have had experiences with private-public partnerships. And I think Francois has highlighted some issues that we, the reasons why we brought this discussion is, for example, how do you make sure that the ministry or the public entity continues to drive the agenda, as opposed to a private company trying to fulfill its agenda, its goals, which are often driven by financial gains. So I would like to open the floor to reactions, comments, and questions to the presenters or to other people in the session. And yes, please have your video on if you can. And remember to unmute when you're talking. I guess I can start by asking some questions, and then maybe others will be inspired. So now it's you, Francois, who is left. And yeah, so one of the issues that we're talking about here, that we're discussing before, were really around governance and how you set your priorities and have the private entities join. And we saw, for example, that for the Nigerian example, there is already a policy that guides these interactions. Is this a similar situation in Rwanda that should become really how things are done everywhere? Do you have a policy that guides how you interact with private companies, or do you negotiate when they come?
Yeah, thank you so much, John, again. So yeah, we do have now, and but of course, this partnership with Electra Foundation was probably not easy to negotiate, because they are not really for profit, but especially, of course, we are having also other really purely private companies that we are working with. So to be able to solve some issues that might really come along, so we have established a public institution called Rwanda Development Board. It's an institution that is in charge of promoting, private investment in the country, mainly external private investment. We have established the PPP guidelines or PPP rules, public and private partnership rules and the guidelines that are guiding, all those private partners that are willing to come and work with the government of Rwanda to work on any project, not only health, but also other development projects. So there are a set of really guidelines, that you have to follow, and also, from really presenting the project, from going through a feasibility study, so things like that. So I think they are here, and it's really helping really to coordinate, but also because not only really having private companies coming and drive you, but also we don't want them also to come and fail, because we should really make sure that really we are also putting in place some incentives to make sure that they can work in a conducive environment, and also make sure that we are supporting them to be able to be successful. So these are things that we managed to put in place to be able to to promote the partnership with private companies. Thank you.
Yeah, indeed, that's also a good point, because I guess with the Electra Foundation, it's not for profit, so the funding comes from somewhere else. But if it is, let's say, a hospital that needs to survive, they have to get some money from the work that they provide. So it's important that you have guidelines on how this is, how you enhance and how you promote the success of private companies. I see a hand raised by Anna. I encourage everyone else, if you can't speak, you can also type in the chat. But let's hear from Anna. Comments or questions?
I have a question. Hi, Francois. Well, I have two questions. One is if you could speak a little bit about the challenges that you had in developing this partnership with Electra Foundation, and what did you do to overcome those challenges? And the second one is, what would you suggest that countries can do to actually go out and find these type of partnerships? Did they come to you? Did you, how did it start, this thing? Because I think that this is also part of the, where do you look, how to connect with people, and et cetera, et cetera. So thank you.
Yeah, thank you so much, Anna, and pleasure to see you. So what I can say is that really we did not have really many challenges, because it was, I think they came to us actually. They came to us because if you look at, especially in this area of cervical cancer prevention and control, the country has really done amazing things with the vaccination program. And some of these foundations, some of these organizations think that maybe, of course, I'm not really probably saying that it was like, just because this was a new foundation actually. They wanted just to prove that really their initiative can work, and really they can achieve something that will help even them to be able to go out and also mobilize additional resources. So they say that, okay, Rwanda is organized, can be able really to help you to, to pilot new things, to be able, that this was not really, because they approached us through our embassy our ambassador to Sweden, so proposing really to partner with us, to support really our journey towards cervical cancer elimination. But of course, there were some few things that we had to discuss and have a common understanding, data ownership, but also some of the interventions that, we were not really easy to implement as the government. That's why we brought on board these other local NGOs to work with them to be able to implement some of these things that might be difficult for the government to implement. But after really seeing that, okay, we have been able to screen those 20,000 women in 4 months, they have now committed to screen the remaining women, so that we can show that in that district we can have 100%, even if of course probably might not be possible, but at least be able to reach the 70% that is now recommended by the WHO. And second, so how do we go and approach those other partners? And we have seen that we have a cancer control plan, yes, but it has got some information that can help people to, to see what as a country we would like to achieve. But on top of that, and of course with your support, we are now finalizing now the National Cervical Cancer Elimination Strategy, which will be really a strong tool, which will be a strong document, of course, to guide the interventions towards elimination of cervical cancer, but also to mobilize resources, to show partners that, look, I'm organized as a country, I'm committed really to show that it's possible to eliminate cervical cancer. And this is how, as a country, I want it to be done. So please bring your ideas, bring your support, and then we can be able to celebrate our achievements together. So this is what we are doing. And I think after having the document endorsed, we should really make sure that it's really widely disseminated, not only in a country, but also with all these other partners that we have, all over the world that might be interested, in this cervical cancer cause. Yeah, thank you.
Thanks. I actually had similar questions with Anna on some of the trouble that you've met, some of the challenges that you've found interacting with private organizations, if they quickly align with, and maybe for Elekta it worked out, but do you have examples of, let's say, where the whole thing just couldn't work because they had different agendas than than the government has, or than Rwanda Biomedical Center has? Has this happened in the past, where you thought, okay, this would have been good, but the private company thinks, or they want to do something else than we want to have, and so it can't work out? Are there some examples?
Yeah, of course there are. There are some examples. So if you look at maybe not only myself, but also other people in the ministry at the Rwanda Development Board, most of the time we are receiving offers from those private companies. But if you go deep and you analyze, you find out that, okay, there are some, how can I call it, things that are not really clear. And then, because part of those guidelines, we need to make sure that this intervention can be sustained. Is this because we have set sort of, also criteria to be able to choose, is this project, needed? What is coming to address? Is it something that really as the government can we be able to, to cover, to continue even, because at the end of the partnership, are our people able to do, to consume these services? So these are things that, for instance, so let's say in cancer management, there are all those newer therapeutics, that our countries cannot be able to access. Still, our countries are still struggling with even the basics. And you can find out that if someone is proposing to give you a treatment that will cost maybe like $10,000 per dose. So and even if maybe it's really good, but saying that, okay, I can start, but once you start, you should be able to continue providing those services. And then if you analyze, you find out that, okay, this is something that's probably out of my reach as a country. Let's maybe focus on those core things, and then maybe those enhanced or fancy things can come later. So we have some examples really with all those issues.
Yeah, indeed. Sustainability is an important issue. I want to allow someone else to ask. Jolene, you have your hand up, and then I'll come to you, Pamela, after Jolene.
Thank you. That was a great presentation, Francois. I think you mentioned a little bit about the sustainability aspect, but my question was, how long are they willing to invest on this project, and the possibility of scaling up to other districts? I feel like you've mentioned, but I just wanted a clarification on that. And my second question is on payment. I know you mentioned a 10% co-payment, and I'm wondering if the organization usually perhaps tries to get insurance for the uninsured so that they don't have to incur out-of-pocket costs if they need cancer treatment. Usually for most families in Kenya, for instance, where I come from, don't have health insurance. So it's easier for someone to pay $50 a month for a health insurance compared to having to incur out-of-pocket costs. So for this public-private partnership, I'm wondering if usually that's the route that the organization takes, or if I misunderstood anything, please clarify. Thank you.
Thank you so much, Joyce. So yeah, quickly, we have a 5-year collaboration. MOU, memorandum of understanding for 5 years. So we've started with this project in Gichumbi, but the plan is to scale up, in the other districts that don't have really services. But we say that before we go to other districts, let's first optimize the screening coverage in Gichumbi. So that's why we said that, okay, let's add maybe 20,000 additional women before we can move to other districts. So for the payment for the health insurances, so we are looking at the coverage of course, we have different health insurances in the country, but we have what we call community-based health insurance. It's an insurance scheme that is covering the general population. So where people do pay according to their, incomes, if I can say. So, but the majority of our people contribute around $3 a year per year. And then when they go to their facility, they pay 10% of the total bill. So here, and then we have like socioeconomic, classification of our people. People in the category 1 who are really those really poor people, they don't pay anything. The government covers. But there are also people that are in the second category. The second, the third, and the fourth, they are the ones that should contribute I mean, provide that 10% co-payment. But you know, cancer management is very expensive. Even if it's really even if you have insurance and you have to co-pay maybe $500, some very few people can be able to afford it. So that's how the foundation has really, I mean, contributed to help them to pay that 10%. But of course, before you pay that 10%, you should have the insurance. For some of those patients that do not have insurance, they have supported them to get the insurance. Yeah, thank you.
Thank you. I hope Yolini's question is answered. Pamela, I see your hand is up.
Thank you very much for giving me this opportunity. I've really been getting a lot from the presentations, and I also felt that maybe I can share a part of our experience, especially in the private or public partnership. Our organization is a not-for-profit organization based in Western Kenya, specifically in Eldoret. We work mostly with the community, and a lot of navigation is done. And on how we get to get other partners, we are approached by those who maybe feel that the work that we are doing is something that we can work together. And there is an organization of the First Ladies of, we have counties, and Kenya has 47 counties, and each county has a governor, and their spouses are either ladies or some which are headed by women, their first spouses. So the name has changed to First Spouses. So this process, the agenda was how they can fight cancer, and specifically cervical cancer. And our organization was identified as one of the organizations that they can work with. So what they do, they write to us, asking us to go and work with them. Then before we do that, we go and sit and have a meeting. We do our work plan, we do a memorandum of understanding. Then in the work plan, we say, what can the county do and what can ICI do? We come together. So during the screening, we know the role we are playing and the role they are playing. Through this, we have found so many gaps. Some counties are very committed that whatever they say they will do, they do. Some counties get priorities along the way, even before the period of the MOU expires. They have changed their priorities, but the ones which have stuck to that, they've done quite well, and we have at least helped a lot of people to go through treatment because they are navigated right from the ground. Then how do we say we are navigating them right from the ground? Once we have a meeting and we have a technical working group, the people involved, the stakeholders within that area come together, then we see which partner does what, and so that we don't cross each other's path, but we combine together to do the work. So this has worked for us, though we have not achieved a lot, but it has worked because even through those collaborations and networking, we got some little funding and trained the community health volunteers in some sub-county who are now working as navigators in the villages so that they are able to identify those who have lumps and send them to the healthcare providers in the facilities, where we also trained the healthcare providers how they can do assessment and also pick biopsies. At least these areas are doing well, but it is just a very little percentage. And I think this kind of a method, if it is replicated somewhere, it can also help us to be able to get early diagnosis and to navigate them to the rightful places where they can get treatment. I can see someone asking, Jaylin asking, it is called International Cancer Institute. We are based in Eldoret, and we work with different counties. Right now, we are working with already 15 counties, and most of them who align themselves to the MOU, we have also at least even helped them, work together with them, and they have established continuous screening or continuous facility screening clinics, and some of them have already established cancer centers. Challenges, just as like with any government, when priority changes, you find that maybe cancer is given low priority. Someone may ask about health insurances. Yes, I know it is a challenge, but whenever we go for screening, When we do mass screenings, we involve the National Hospital Insurance Fund staff who go with us to the community. And when we are doing community education, they are also part of the people who educate so that people get motivated so that they enroll into these insurances even before they get sick, because it will help and it will help the family. In case someone is identified with an abnormality, we also encourage them to enroll, and some counties, they have put some little fund somewhere whereby they support those ones who are really needy and are not able to enroll themselves in the local health insurance fund, so that by the time a diagnosis is made, we are able to have this person covered under insurance, though it does not cover all, but at least this has done a lot of difference, and this has also improved the survival rates. We boast of a good number of survivors because of some of these efforts that have been put in place, but it has really not gone so much. But I think this is a method that if it is replicated even in other LMCs, it can work well. Thank you. That's what I wanted to share.
Thank you so much, Pamela, for sharing about the International Cancer Institute. Yeah, I think it's a lot of interesting things coming up there. I see clinical trials going on and all that. Francois has his hand up, so I will allow him to speak before I ask my next question to you, Francois, and also to Pamela. So, Francois, first react.
Thank you. I put my contribution in the chat box, was just to recognize the work that ICI is doing in Kenya, but also beyond Kenya. So we're having very amazing projects with them in Rwanda. So it was just that one.
Yes, I do remember that Frederick Chite was speaking at the event, the cancer event. But I wanted to ask something that maybe not you might give, but you probably have sort of figured out. What incentives do you give to private companies so that they can venture into what might not be very profitable or not attractive, a field like healthcare? And for example, if you're working with I assume that you're working with, let's say, with the Electra Foundation, this is part of their corporate social responsibility, and it makes them it keeps the company it gives the company a good image, and that can help boost business, can help with the company to become more profitable. I know that at some point they might ask you to procure, let's say, Electra Foundation makes radiotherapy equipment, for example, or if it's a pharmaceutical company, they might ask for, I don't know, some approvals to sell their product in the country. What kind of incentives do you give this? Do you give tax holidays? What do you give? Do you give waivers for some? How do you entice them to come and invest?
Okay, maybe for ICI, which is still a young organization, we have not reached that level. But what actually happens is the motivation they get by the survivors that we have. Whenever we want to have like a meeting for the survivors and they come and see how people have really gotten well, this is one reason that makes them even to give us some medications at subsidized price. Because when it is done at subsidized price, then survival rate is high. It means many people will have confidence even in the medications that they are giving. So as that is the way that we have used. And also some few companies, we approach them as a part of their social corporate responsibility. Some of them can say, like, we can maybe pay for like 5 patients for their National Hospital Insurance Funds, because that one, if you pay, like they do like a 2-year payment for some patients. When it is done, they are sure that whenever a patient will come and needs that drug, which is maybe what part of what they are marketing, the patients will be able to get. So when we get that, when the patient is able to pay, when the insurance is paying for the patients, it means even the purchase of those drugs will go up. So that is another way of getting the companies motivated but mostly through the survivors. When we have the survivors and we have a meeting for them, and maybe we call like one company to come and do a breakfast for them, and they see the way those people feel good when they have gone through the treatment and the help that they have gotten, they get motivated to help and do more. But we've not gone very far. At least I can say we are on a milestone. And thank you very much. We work with Rwanda. I think we've been there even for some trainings, and also Tanzania and Uganda. So we are beyond Kenya only. Thank you. Sorry, I didn't remember to mention that, but Prof. Chite is my CEO.
Thank you. Francois, do you have comments on how you incentivize and entice private companies? Do you promise to buy from them? What do you do for them?
I think there are different, ways of incentivizing them. So if I can mention really like 3. So of course, tax holidays. So this is something that we are doing for many companies, really bringing those things that are needed in the country, but as the government, we cannot be able to put in place very, very quickly. So like if you bringing it, now we are struggling because we are still sending patients outside for PET scan, for those people in need of nuclear medicine. So and now we are working with different companies to see the best one, but also, some of the incentives like tax holidays, you bring your equipment without paying taxes. And so these are things that, and even commit to buy your services actually. So commit to buy your services, even go up to committing the quantities, saying that, okay, if you bring it, you commit maybe to find maybe 5,000 patients every year that you should really be treating. And then the government will really, put this service to the health insurance schemes. So these are some of the things that, of course, sometimes we even go beyond. If really they need to do some constructions, we provide a land for free as the government. So there are different incentives that we are providing to them. But of course, all of these depend on really on the importance of that, investment to our people. If it's something that really the government cannot do, of course, we try to provide many incentives to those companies so that they can come, because they are coming to respond to a real need, and then it's something that the government cannot really be able to do quickly. So that's how things are being done. Thank you.
Yeah, thank you. This session can go until 5:30 East African time, or 3:30 where I am, or I don't know, probably half of after the hour, wherever you are. But we don't have to stay if there are no more questions. So please put them in the chat or raise your hand so that it's not only me who is interacting with the presenter. I do have one last question that I want to give, and then if anyone else wants to ask, you can put up your hand. So the last question from me is, are there instances where you feel that you have been exploited by the private company, that the company has maybe done so little and has said that they did so much, they present that they've done so much, and this I've seen a bit of this happening where someone delivers, I don't know, some number of doses for chemotherapy, for example, and then they go and put on their website where the people who are funding the entire cancer control initiatives in this country. And I think that is misrepresentation of what happens. And usually, the governments or the hospital directors are not happy when something like that happens. Have you had something like this, and how do you, what do you allow for people to ride on you, basically, if I could use that word, to say they're doing this and they're not doing, or they're doing very little than what they say they are doing? Is that a clear question, Francois?
Hello, John.
Yes. Did you get my question? Have you had instances where a company does little and claims to do so much, so they ride on the fame, which they did not actually do?
Yeah, I mean, these are things that do happen, do happen. I mean, of course, it's not only in the health sector, but also in other sectors. But let's say, I mean, talking from our experience, so just as much as possible, trying really also to have very good working relationship with these companies, with these private investors. Because, but of course, as a country, we need also to take a decision and make sure that we are protecting our people. So when such things happen, so try to negotiate, because it's also part of the, the agreement that we do have with them. And most of the time, all those things can be settled amicably, but I don't really have any case where we were supposed to go into court justice, but yeah, they happen. But that's why we need, once you have such a partnership, there are also people from the government that are in charge of working with those people on a daily basis to make sure that really they are supported. We know what they are doing, make sure once really problems arise can be solved quickly without really going up to that level of, going to court of justice and so on. Yeah.
Thanks. I asked this. This is very common in this day and age where people take pictures of themselves when they're giving away food to the needy, and they have to put this on Instagram and whatever. That trend. And I imagine that it's good for the marketing. It's good for the company to show that they're doing something good. But sometimes they maybe take it too far, and you feel that they're exploiting, the relationship. But it's good that you already think about these and you sort of draw the lines. I see Anna has raised her hand.
Yes, I just wanted to add that it happens with governments, it happens with patient organizations, it happens at all levels, these things. So I think that understanding who's your counterpart, Francois emphasized the fact of having a strategy, a plan that you can show to your partner. It's also important to see what is the strategy of your partner. So go on the website, ask for the strategy, and get to know that organization. If it's a philanthropic institution, might be a little bit easier, but just try to understand their strategy, and then you might be able to address some of these issues at the beginning of the partnership and not wait until the end when you see the picture of that institution, kind of, I don't know, overestimating the impact that they're having in the country. I worked for a foundation for 10 years, and it is also good, to understand your partner, whether it's a foundation or a company, to understand that the person you're dealing with, they do have to report up to a board, to funders. So getting these things at the beginning, it really helps the quality of the partnership, I think. Thank you,
Anna, for your contribution. And Francois, again, thank you so much for sticking around. I see you have to leave, as you mentioned in the chat. Very interesting discussion and insightful on how you make sure that the relationship works out. And we're looking forward for nice things coming out of your relationship with Elekta and many others. And also, Pamela, the good work that you're doing in the region. I don't know if there are any other questions, any other discussions, but at least the discussants have to leave. And I don't see much questions from the chat. So I'll ask if there's any announcements from Charles, and then we can end early today.
Well, thank you so much, Dr. John Black, and then thanks to our speakers, Dr. Francois and Dr. Firani in absentia. We are so grateful for being with us today. And I would also like to thank our participants for today. Thank you for attending and being active. So we are going to share the recording in the course of next week so that we can interact more with that and with that. So please look out for that. Our next session will be held on March 16th, we are going to be looking on a topic on health workforce. So please look out for the agenda in the coming weeks with more details on the specific details that we'll be covering. Otherwise, I think we've come to the end of our session. Thank you very much and enjoy the rest of your day. Bye.
Thank you. Bye, everyone.
Thank you.